here, with the time, we will have a drooping on the nasolabial fold and we will increase the fold. So I will be injecting on all the other superficial fat compartments, the middle one, the medial one, and we have another superficial fat compartment, which is the infraorbital superficial fat compartment located here, but we will not be injecting it. The reason why is that she already lost her infraorbital superficial fat compartment, and this is why we have the T-trough appearing more. It's because we have now, in her case, a thin skin already in contact and with the orbicularis oculi muscle, and this is why we have this blue color. It's because we have the thin skin straight stick to the orbicularis oculi muscle. The third reason of her T-trough is also because of the bony resorption. With the time we are losing the interior projection of the infraorbital rim. And the third reason of a T-trough at that age of our patients, it's also because we have an increase in volume of the fat pads. So these are the three reasons of our T-trough. So today, if I want to also remove the shadow of her T-trough and her lid cheek junction, regarde toujours devant toi, I will be using the dedicated product for that. I will be using RH2, Redensity 2, sorry, Teoxane Redensity 2, with the lateral entry point here. I will be injecting 3 small boluses in the T-trough, and I will be using the same entry point for working again on the supraperiosteiod layer, but here I will do like a fanning technique with hydrodissection with Redensity 2 here. So now that we have our target, where are the dangers of the midface and the T-trough? The first anatomical danger is coming, of course, from the facial artery. And we know that the facial artery is emerging here between the mandibular ligament and one of the multiple pre-masseteric ligaments that we have here. So it can be everywhere, but here it will be deep in contact with the bone. And this facial artery, of course, will have a lot of variation, but in a classical way, we have a facial artery going on the nasolabial fold with a lot of variation once again, because here the artery can be superficial, but it can be deep also. So we have to pay attention to this area. In between, of course, my facial artery will give me the branches for the lower lip, inferior labialis arteries, superior labialis arteries, all the arteries for the nose, and in a classical way, the artery will be finishing here in the angular artery with the connection that you know already with the supratrochlear artery. So where is the supratrochlear artery? France, les sourcils, s'il te plaît, from. You see this first glabellar line, it's the supratrochlear artery. And if my patient look straight, you see it's not the mid-pupillary line, but the mid-iris line where is emerging the supraorbital artery here. So whatever the direction, the most important is that security line that you know, the expert to expert security line up to 2 centimeters, where here the vessels are already superficial and here they are deep and they can be everywhere. I'm talking about the supraorbital artery because you know that we have a connection with the superficial temporal artery. We can palpate this artery just right here. We have a vertical branch and a superficial branch and the interior branch that will be connected. In the midface, my facial artery can be also in the mid-cheek groove in 20% of the cases. And as Patrick told you, up to this line, the facial artery cannot be up. So we have some security line. The first one is the mid-cheek groove the zygomatic arch, and the temporal line. So in between, we are safe if we want to inject there. But we have always in the mid-cheek groove. This is the reason why my entry point is lateral. We have the facial vein. So this is why I'm injecting it in a perpendicular way here in order not to cannulate a facial artery that can be in my mid-cheek groove here. So for the T-trough, I will be avoiding also the infraorbital nerve and the infraorbital artery. With my small finger, I can locate the infraorbital foramen here. So my entry point will be down lateral and up to this infraorbital nerve. Is it okay, Nazila, for the mid-face and the T-trough? Can you see? We don't hear them? Yeah, they are here? Okay.
Yes, we can see very well, Nabila.
Okay. The last step of my treatment will be the lower face. But before, of course, we will use the gunshot technique a little bit modified with using a gunshot technique with RHA4 deep into the temple with multiple boluses here. And that will be easy to lift also the lower face with injection in the temple regarding this line of ligament that Dr. Sebastian Cotofana has already described. So all the injection made lateral in the lateral face will have a power of lifting of the layers, the two other thirds that are under this temporal injection. When we inject medial to this line of ligaments here, then we will have only a projection. So projection in the medial midface, lifting effect on the lateral face. So for that, I will use the other side just to show you how we can create a natural Texas contour like our patient wants here in the Middle East or in Morocco. I use a tongue depressor to locate my mandibular bone. And I draw in a female patient a 190 degrees to project the angle like this. For that, I will be using, you can lay down. I will be using the multi-layering technique because here I know that in the mandibular angle, I have no danger deep, no danger superficial. So I can work with the bolus technique with Teoxane ultra deep to give first a projection, a support of the bone, and then for the definition and the precision of the mandibular jawline contour, I will be using Teoxane RHA4 superficially here with the cannula technique. Of course, I will not inject on the jaw, but I will be using RHA3 with the cannula technique also to fill this mandibular line and the pre-jaw. And at the end, projecting the chin with, again, a multi-layering technique because here we have deep fat compartments